Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are on YouTube and you can view them at your convenience. We also have a Telegram group for accessing all lecture related information. You can join the group, and we have a Google Drive where all the lecture PDF is available, which you can always download, and we have a master integration key to navigate between the PDF and the YouTube. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures, which is convenient for teachers, for students, and for the organizers. And in phase 3, we are with dermatopathology, which is Pursue 26. And in dermatopathology, we are with Pursue 26F, which is psoriasiform dermatitis, and we are streaming from Medical College, Solan, Himachal Pradesh. And to talk on psoriasiform dermatitis today, we have Dr. Karishma Sarin. She's an MBBS from Government Medical College, Amritsar, an MD from the famous GMCH, Chandigarh. Presently, she's an assistant professor at the Department of Pathology at the Maharishi Markandeshwar Medical College and Hospital, Kumarhatti, Solan, Himachal Pradesh. Her areas of interest is hematopathology, histopathology, and cytopathology, with multiple publications in international and national journals. So I would request Dr. Karishma Sarin to start the topic, psoriasiform dermatitis. Ma'am, please start. Thank you so much.
Thank you so much, sir, for this wonderful opportunity. Hello, everyone. I am Dr. Karishma Sarin, working as an assistant professor. Today's topic of discussion is psoriasiform dermatitis. I'll be discussing this topic under the following headings, starting with the introduction, then the history, its classification, various etiological causes, its pathogenesis, clinical and histopathological features of certain entities, and finally concluding with the summary. Starting with the introduction, what is psoriasiform dermatosis? This refers to a group of disorders which clinically and histologically simulates psoriasis. It represents a wide spectrum of inflammatory conditions which includes various clinico-morphological entities. The word psoriasiform means like or in the shape of psoriasis. Psoriasis is the oldest of all the recorded dermatological disorders. Hence, it stands as a prototype of psoriasiform eruptions. Now, a brief about its basic histology. You must be knowing that the skin is basically divided into three parts histologically. The uppermost is epidermis, middle part is dermis, and the lowermost or the lower part is hypodermis. The hypodermis basically includes adipose tissue. Dermis is further divided into the upper papillary dermis, and the deeper one is the reticular dermis. And the epidermis, it has further layers. The outermost layer is stratum corneum, then is stratum granulosum, stratum spinosum, and stratum basale. Starting with its history, the first classification was given by Pincus and Mrigan, who grouped these disorders under two major categories. One, in which there were definite presence of suprapapillary exudates and parakeratosis. And the other category was under a diagnostic dilemma. Then this classification was further modified by Reed and Clark, in which the reaction pattern recognition method was taken for categorization of such disorders. Then further, this was modified by Ackerman and Mim, who modified these criteria to address the pathogenesis, its etiology, as well as the reaction pattern seen in the dermal part of these psoriasiform disorders. Then Farmer and Hood came up with the idea and they classified these disorders into three major groups depending upon the presence or the degree of psoriasiform epidermal hyperplasia. Finally, Elder et al. Classified psoriasiform disorders based on the presence of predominant cell type present in the dermal part. Starting with its classification, the first Pincus classification, the group 1, in which there were definite presence of suprapapillary exudate and parakeratosis. The entities included were psoriasis, Ritter syndrome, acrodermatitis continua, impetigo herpetiformis, seborrheic dermatitis, and astetotic dermatitis. Group 2 entities included were nummular eczema, pityriasis rubra pilaris, lichen simplex chronicus, subcorneal pustular dermatosis, folliculitis, impetigo, and pustulosis palmoplantaris. Then Farmer and Hood classified under three major groups. The group 1 included were in which the psoriasiform epidermal hyperplasia was considered as its characteristic feature. The entities included were psoriasis, Ritter's disease, lichen simplex chronicus, pityriasis rubra pilaris, pellagra, inflammatory liner verrucous epidermal nevus, disorders associated with acquired immune deficiency syndrome, acrodermatitis enteropathica, and necrolytic migratory erythema. In group 2, the psoriasiform epidermal hyperplasia was seen as a frequent feature and the entities included were contact dermatitis, nummular dermatitis, seborrheic dermatitis, psoriasiform syphilis, and mycosis fungoides along with pityriasis rosea. The last category in this, the psoriasiform epidermal hyperplasia was an occasional feature and the entities included were dermatophytosis, candidiasis, and Norwegian scabies. The last classification, which was given by Elder et al., according to the presence of predominant infiltrate present in the dermis. Lymphocyte predominant entities are nummular dermatitis, pityriasis rosea, and lichen simplex chronicus. Plasma cell predominant entities included are psoriasiform syphilis and arthropod bite reaction. Eosinophils predominant entities are chronic allergic dermatitis, exfoliative dermatitis, and cutaneous T-cell lymphoma. Neutrophils predominant entities are psoriasis, dermatophytosis, and Ritter's disease. Coming on to its etiology, the broad categorization is according to the type of lesions. First is erythematoscaly lesion, second is eczematous lesions, infective lesions, malignant causes, drug-induced causes, and others. Erythematoscaly lesions includes first is psoriasis, then comes disorders of keratinization. These includes pityriasis rubra pilaris, erythrokeratodermia, papillolefevre syndrome, and lamellar ichthyosis. Other entities included in erythematoscaly lesions are Ritter's disease, pityriasis rosea, and erythroderma. Next is eczematous lesions, which includes seborrheic dermatitis, Nummular dermatitis, lichen simplex chronicus, and allergic contact dermatitis. Infective causes includes viral causes including AIDS-associated psoriasiform dermatitis. Spirochetal causes include psoriasiform syphilis. Fungal causes includes dermatophyte infection and candidiasis. Parasitic infections includes leishmaniasis and Norwegian scabies. Malignant causes includes mycosis fungoides, Hodgkin's disease, and Bayes syndrome. Drug-induced causes, many drugs contribute to the etiological cause. These include anticonvulsant drugs, fluorescent sodium, infliximab, ecodextrin, metformin, terbinafine, recombinant granulocyte macrophage colony stimulating factor, venlafaxine, doxorubicin, calcium channel blockers, botulinum toxin, beta blockers, mitomycin, captopril, digoxin, quinidine, lithium. Other causes include inflammatory linear verrucous epidermal nevus, pellagra, necrolytic migratory erythema, acrodermatitis enteropathica, and parapsoriasis. Also included in other causes are Kawasaki disease, chondrodysplasia, sarcoidosis, psoriasiform acral dermatitis, psoriasiform and sclerodermoid dermatitis of the fingers. All these lesions have psoriasiform epidermal hyperplasia. Now coming on to its pathogenesis. Psoriasis has a variable geographical and ethnical incidence. It is considered as a multifactorial immune-mediated dermatitis. So the pathogenetic mechanisms are under the regulation of keratinocytes, immune cells, and various cytokines. The immune-mediated mechanisms basically involve action of certain antigens including human leukocyte antigen B13, BW17, and B27. Genetic mechanisms include allelic instability. Inflammatory dermatosis is characterized by hyperproliferative epidermis due to keratinocytes hyperactivation and intense inflammatory dermal activity, which is supported by various inflammatory cells including dendritic cells, neutrophils, T lymphocytes, and macrophages. Now, the abnormal skin activity in psoriasiform disorders is associated with various proteins with different cellular activities. And the proteins included in this are STAT protein. What is STAT? STAT is signal transducer and activator of transcription protein, S100 protein, WNT family 5A protein, P53 tumor protein, enzyme biomarkers, ROR gamma, that is retinoic acid related orphan-nuclear receptor gamma protein. Then also included proteins are tissue necrosis factor like weak inducer of apoptosis, aquaporin 3, galectin 3, and soluble form of beta amyloid precursor protein. They all contribute to the abnormal skin activity because of their different cellular activities. Then normally in our body, the T regulatory cells, they help to keep up the immune tolerance from the various commensal microbes. But in psoriasiform disorders, the role of T regulatory cells is significantly decreased because of the number of the T regulatory cells and their activity is significantly decreased and depressed, which leads to loss of preservation of the skin immune tolerance to various commensal microbes. Another contribution to pathogenesis, in a recent study, they demonstrated the role of microRNA 187 and microRNA 126, which is positively correlated with the psoriasis severity index. And its upregulation promotes proliferation and keratinocytes inflammation by suppressing cell apoptosis. Another major mechanism is interleukin 1 beta and interleukin 1 R signaling pathway, which may be involved in amplification of skin inflammatory cascade through the regulation of dermal interleukin 17 producing cells and stimulation of keratinocytes. Now, starting with the particular entities, first is psoriasis vulgaris. Clinically, the patient will present with erythematous lesions and there will be presence of thick silvery scales over the extensor regions. Basically, the extensor regions of the body are affected and they usually present with onychodystrophy. And what is onychodystrophy? That is thickening of the nails and or yellow brown discoloration of the nail plate. Here clinically, this is the clinical picture of these are the thick white scaly plaques over the dorsal surface of the hand, and this is the thickening of the nail plate, yellow discoloration of the nail plate. This is onychodystrophy. Histopathological features include hyperkeratosis, parakeratosis, orthokeratosis, thinning of the granular layer. There is usually frequent mitosis noted. Acanthosis will be present and there is uniform elongation and fusion of the rete-ridges. This is the photomicrograph of H&E stained slide. This is a low power view and here you can see this is hyperkeratosis. The stratum corneum, there is thickening of the multi-layering of the stratum corneum. This is hyperkeratosis. Now normally, this is the diagrammatic representation. Normally there is no nucleus in the stratum corneum, in the superficial layer of the keratinocyte. But when there is retention of the nucleus in the stratum corneum, then the term parakeratosis is used. Parakeratosis is what? Hyperkeratosis with retention of the nucleus. This is the high power view of showing parakeratosis. This is blue colored nucleus, basophilic nucleus. This is the retention of the nucleus in the stratum corneum. Now, what is acanthosis? That is thickening of the epidermis. Usually, this is the diagrammatic representation showing the epidermis. These are the keratinocytes and this is the basal layer. But in acanthosis, there will be proliferation of the keratinocytes and the epidermis will be thickened. This is seen in psoriasiform lesions. This is micrograph showing this is acanthosis, thickening of the epidermis and there is elongation of the rete-ridges. About 75% of the cases, there will be presence of pycnotic neutrophils in the stratum corneum and they are termed as Munro's microabscesses. Few of these neutrophilic aggregates may be present in the stratum spinosum and they are termed as spongiform pustules of Kogoj. And in the superficial dermis, there will be presence of perivascular lymphocytic infiltrate along with T cells and Langerhans cells. This is the micrograph showing collection of the neutrophils in the uppermost stratum corneal layer and this is known as Munro's microabscess. Again, this is a collection of neutrophils in the stratum spinosum layer forming a pustule, and this is pustule of Kogoch. These neutrophilic collection, pustule formation, they are causing degeneration of the adjacent keratinocytes. In early or eruptive forms, the changes are usually non-specific and are mainly located in the dermal part. That includes superficial perivascular lymphocytic infiltrate, papillary edema, dilated capillaries, and extravasation of RBCs are usually noted. This is a micrograph showing this is mononuclear dermal infiltrate around the vessels. This is perivascular infiltrate. Also noted in early lesions are focal parakeratosis and neutrophilic migration in the overlying epidermis can be noted. The neutrophilic infiltrate is usually more abundant in the early or the eruptive forms than in typical late forms. Now, the psoriasis has various histopathological variants. The first one is psoriatic neurodermatitis. In this, the plaques are usually present on the elbows and knees, and this is considered as a special form of psoriasis which is associated with lichen simplex chronicus. Next variant is scalp psoriasis. In this, histopathologically, there will be sebaceous gland atrophy and smaller hair follicles will be seen. Next is nail psoriasis with hyperkeratosis and spongiosis. Then erythrodermic psoriasis. In this, the histopathological features are usually then seen same as that of the typical psoriatic lesions. Then is the follicular variant, in which there will be presence of follicular plugging along with perivascular and perifollicular dermal inflammatory infiltrate. Last variant is annular verrucous psoriasis, and in this there will be presence of exaggerated papillomatosis. Next entity is pustular psoriasis. Clinically, there will be typical plaque type lesions. Sterile pustules will be present on palms and soles, and confluent pustules will be present on trunk and extremities. Here clinically, this is the clinical picture. You can see variable sized gray-white pustules which are present on the palmar surface of the hand, and these are the variable sized pustules which are present on the trunk. During pregnancy, pustular psoriasis is manifested as impetigo herpetiformis, and usually there is generalized distribution of these lesions all over the body. Histopathologically, there will be presence of characteristic spongiform pustule of Kogoch, and how these pustules form. This is due to the neutrophilic migration from the superficial dermal capillaries to the intercellular spaces of edematous malpighian layer, leading to the keratinocytes degeneration and formation of unilocular pustules. This is the micrograph showing a unilocular pustule, and there is collection of the neutrophils. Here also you can see there is collection of the neutrophils which is destroying or degenerating the adjacent keratinocytes. Next entity is Reiter's syndrome. Clinically, it has a triad of urethritis, arthritis, and conjunctivitis. Histopathologically, it is similar to that of typical psoriasis. Next is pityriasis rubra pilaris. This is a chronic papillosquamous disease. It has a seborrheic dermatitis like onset which evolves to confluent truncal acuminate follicular papules and perifollicular erythema. Histopathological features include alternating areas of ortho and parakeratosis. Follicular plugging may be noted along with irregular elongation of retiridges. Epidermal hyperplasia along with hypergranulosis. And in the dermis, there will be presence of perivascular lymphocytic infiltrate. This is the photomicrograph showing there is the granular layer with parakeratosis, that is retention of the nucleus, along with orthokeratosis, that is, what is orthokeratosis? Hyperkeratosis without the retention of the nucleus, giving a basket weave appearance. This is acanthosis, that is thickening of the epidermis. Next entity is lichen simplex chronicus. Clinically, it has well-defined papules or plaques, which are usually hyperpigmented and are associated with pruritus. It usually involves the lower lateral legs, posterior part of the neck, and flexural areas. Histopathologically, there will be thickening of the epidermis and papillary dermis. Hyperkeratosis, hypergranulosis, acanthosis, and irregular elongation of the retiridges is usually noted in these type of lesions. In dermis, there will be presence of fibroblasts and perivascular lymphocytic inflammation will be noted. This is the photomicrograph showing this is hypergranulosis. This is the dark outlined. And this is irregular elongation of the retiridges, and there is collection of dermal collagen. Last entity is large plaque parapsoriasis. Clinically, it is usually idiopathic and asymptomatic. There will be presence of irregular asymmetrical large erythematous patches and plaques involving buttocks, flexural areas and breasts, and these lesions are usually unresponsive to any specific treatment. This is the clinical picture of erythematous large lesions over the back. Histopathologically, there will be irregular acanthosis with parakeratosis and focal basal cell vacuolar changes. Superficial dermis usually show fibrosis and perivascular lymphocytic infiltrate. In chronic lesions, there will be presence of band-like dense inflammatory infiltrate with papillary dermal fibrosis. So this is the micrograph showing hyperkeratosis with parakeratosis, acanthosis, and this is dense dermal infiltrate. This is the band-like infiltrate in the dermis. So to conclude, psoriasiform dermatosis represents a complex inflammatory skin diseases. They share most of their histopathological features, thus representing a challenge in histopathology. Using the clinical data, a thorough evaluation of the microscopic features, the range of differential diagnosis can be decreased and a more accurate diagnosis can be achieved. So, understanding the pathogenic mechanisms and closely monitoring the development of these major psoriasiform dermatoses can lead to new therapeutic opportunities targeted to the specific type of inflammatory lesion. Thank you so much. Thank you for your patience. I hope that I was able to explain it well. Thank you.